Good morning. We're going to talk a little while this morning about hydrodissection. Okay, well, what is the purpose of hydrodissection? With phaco surgery, you must rotate the material across from the entry wound. You can only access material pretty well directly across from the entry wound, maybe about 45 degrees to each side. So you have to bring material to the tip in the end so you don't get all cramped up and have a problem with the capsule. Freeing up the cataract from the capsular bag allows you to rotate it freely, and it's an important step. It looks very simple, but it's harder than it looks, and I found that for many residents, hydrodissection is the most difficult step in phaco cataract surgery to do well consistently. Sounds odd, but it usually, or it often ends up being that way. But if you can get that mastered, it really helps make the rest of the case go well.
An understanding of lens anatomy and how hydrodissection impacts that anatomy has allowed us to develop this simple technique to avoid retained cortex. Cortical fibers develop from the lens epithelium. The lens epithelium
in this area
is a simple cuboidal epithelium that lies beneath the anterior lens capsule. The lens epithelium, when viewed through the anterior capsule, can be separated into zones based on the density of connections to the underlying cortex. The central zone, in blue, occupies 80% of the anterior capsule and has few connections to the underlying cortex. The remaining zones of the lens epithelium, in red, extend just beyond the lens equator and are densely adherent to the underlying cortex. The posterior capsule has minimal connections to the cortex. Again, in cross-section, the areas of dense attachment of cortex to lens epithelium are shown in red, while the areas with weak attachments are shown in blue.
So weak attachments otherwise.
There is likewise a gradient of intercellular connections between cortical fiber layers. Intercellular connections between cortical layers decrease as you move from peripheral to more central cortex.
So as you saw, the lens body is formed by epithelial cells, which are near the equator. Then they have fibers which elongate, or part of the cell body that elongates anteriorly and posteriorly to form the interlocking lens fibers. There's a loose connection of the fibers to the capsule anteriorly and posteriorly, but much more adherence around the equator, usually more with softer lenses than with harder ones. And this is the area which we have to free up in order to be able to allow lens rotation. You need to inject immediately under the capsule to begin to break the adherent cortex. You'll generally go out under the capsule a little bit. Don't put your finger on the plunger yet. Lift a little bit and then gradually inject until you can see a fluid wave go around behind the lens. If you don't get a fluid wave, go to another area and try injecting again. This separates some of the attachments, but often not very widely, and you have to be very careful not to over-inject initially if you're having a problem.
Exactly how does standard hydrodissection impact lens anatomy? With standard hydrodissection, BSS is injected beneath the capsular rexus. The fluid descends radially between the cortex and the lens epithelium. Because of the dense connections between the lens epithelium and the peripheral cortex, the fluid cannot spread laterally. When the fluid reaches the posterior capsule, a fluid wave is seen clinically as the weak connections between the cortex and the posterior capsule are separated. The nucleus prolapses anteriorly as the fluid wave progresses. The fluid wave stops at the posterior edge of the lens epithelium, and a fluid pocket is formed.
Here's your fluid pocket.
Anteriorly. The lens remains adherent to the capsule by the dense connection between the peripheral cortex and the lens epithelium.
Now, there are different techniques to free up the remaining adherent areas, which at this point are pretty much all around. And one that you find works most of the time is to slightly tilt the lens backwards by pressing down slightly in each quadrant near the capsular axis. Then you can see fluid move around from behind the lens to come forward as you slightly displace it. If the lens doesn't rotate freely after doing that, you can inject some more under the capsule in another area, tilt it again. It is very important to bring the fluid anteriorly after each injection to avoid blowing out the capsule. When you're injecting, if you watch the capsular axis, you inject until you get a slight increase in size of the capsular axis, usually no more than 1 millimeter. If you keep going, you'll tilt a quadrant of the lens up out of the bag. You can gently replace that, or sometimes it's safer to just remove it from that position. Be gentle.
If the capsulotomy is undersized relative to the diameter of the nucleus, the bag is overinflated, capsule decompression becomes difficult due to intraoperative capsule block. Fortunately, capsule blowout is a rare occurrence and is associated with posterior polar cataracts and posterior lenticomnus.
Or it's also associated with overinflation without letting the fluid come back forward. That is not something that you want to see, is to have the lens sink back into the vitreous. You can do it. You can blow out the capsule if you press too vigorously, trying to get fluid to dissect forward. Excuse me. A lot of people say they like to press centrally, but I find that's not as safe as pressing a little bit in each quadrant around the lens, around the capsular axis. If you're not getting fluid to come back forward, try burping out just a little bit of the viscoelastic to slightly soften the eye. Then try to gently tilt it. I'll often displace the lens slightly centrally while tilting it to bring the fluid forward. And this is a demonstration of some cases of mine doing the hydrodissection. Okay, this is a CHANG right angle cannula. There are different cannulas that can be used for hydrodissection. This one works really well. Go under the capsule, lift a little bit, inject, see that fluid wave go across, then press down slightly in each quadrant. You can see the fluid come back around. And often just one set of that will free it up, and then I will go in down to the hard part of the lens and hydrodelineate to separate the epinucleus. While you're learning particularly, I think it's helpful to hydrodelineate so you have a layer of cortex and epinucleus inside of the hard nucleus that you're going to remove with phacoemulsification. Probably don't have to displace it quite that much, but enough that you can see the fluid come back around. And another, go out under the capsular axis, lift before you inject, gradually inject fluid until you see a fluid wave go across. If you see sort of a scalloped edge as you go across, that means that you are very superficial, which is where you want to be at this point. And then rotate it to make sure it is freed up. And then I hydrodelineate, turning the tip down and injecting onto the hard part of the central nucleus. Inject until you see a fluid wave right there. We want to go across fairly slowly. Then press and press down in near the capsular axis and rotate, hydrodelineate. Sometimes you'll see a separate, it's called a golden ring, a bright ring that appears when you hydrodelineate. One more. Bring the fluid back forward. Hydrodelineate. That one has a very small central hard nucleus. So just press firmly and hold, but just enough to slightly tilt the lens back and help the fluid come around. And if you're having a problem, remove some of the viscoelastic from the anterior chamber. There's a technique called tangential hydrodissection that Dr. John Hart did a video on several years ago. And this works well as either a primary or backup technique for lenses that don't rotate well after other techniques. It can be done with a CHANG right angle cannula, or you can bend a J-shaped Binghorst cannula slightly. It works particularly well with very soft cataracts that often are hard to rotate.
Standard hydrodissection is performed first in the subincisional area. Always visually confirm that no cortex is trapped between the cannula and the capsule prior to hydrodissection. Standard hydrodissection is completed once the fluid wave reaches the far side of the lens. Gentle decompression is performed in the center of the lens. Tangential hydrodissection is then performed until the nucleus with its attached cortex spins freely within the capsular bag.
Yeah, inject as you go around, just under the, whoops, I'm sorry. And he's showing that he used a J-shaped cannula. This is from several years ago. And you can bend it slightly to make sort of a 45-degree angle. Dr. David Chang has an excellent book for learning phaco-cataract surgery entitled Phaco and he includes an extensive DVD with the book. I think it's the first ophthalmology textbook that included a DVD. So I'm going to show you his chapter on hydrodissection pearls from that DVD.
The CHANG hydrodissection cannula is a 27 gauge metal cannula with a 1 millimeter right angle tip, and the tip is actually flattened so that there's a fan-like jet when used with a 3cc syringe. It goes right underneath the anterior capsule with two waves, one hydrodissection and one hydrodelineation. Because the 45-degree tip creates a little point on the end so that the cannula itself serves as a dialing instrument to confirm rotation of the nucleus. So here again, it's used with a 3cc syringe. You see the jet of fluid, and being a right angle, you can get to the subincisional capsular area. And you see that nice slow wave with scalloped edge means it's right up against the interior surface of the capsular bag. The next wave is hydrodelineation, and that's by just angling the tip inward slightly, and then again confirming rotation by digging the little angled tip into the nuclear surface. Successful hydrodissection actually means that the epinucleus is loosened, and you will see this at the end when it tends to come out in one large sheet because it's been loosened from the capsular bag. So again, you slip right under the anterior capsule edge, and if you see that slow wave, you know you've loosened not only the epinucleus but also the cortex. You tip inward just a little bit to create the hydrodelineation wave, and again, you can confirm rotation with the tip. You want to see a nice slow wave with a scalloped leading edge, indicating that your wave is encountering the resistance of the cortex as it moves. And here you'll see the epinucleus is actually turning with the endonucleus, indicating that it too has been loosened by it. And again, although we can't engage the anterior nuclear surface as peripherally, we can still dig the tip into it and rotate it around. One of the pearls is to make sure that your chamber is not overfilled with viscoelastic, which of course does flatten the anterior capsule to help with the capsulorhexis. But then if you burp out some of the viscoelastic, and you'll see here that the eye is indeed soft, you'll avoid having too much viscoelastic compressing the nucleus posteriorly. Again, showing you want to have a soft eye so there's less resistance for the fluid wave to pass underneath the nucleus. Again, leaving the chamber overfilled with viscoelastic compresses the nucleus down into the posterior capsule, creating more resistance for the fluid wave to overcome. The one thing to be avoided is having a brown lens such as this move right up into the back of the capsulorhexis, creating capsular block. And if you were to overfill the bag, it is possible to blow out the posterior capsule. So you see, right after that first wave, typically is used to compress the nucleus posteriorly, breaking the capsular block. This is a patient with exfoliation and a mature brown lens. And you can see that as we tear the capsular flap, the entire capsular bag is moving, indicating that we have very loose zonules. This is often the first indication when you're doing the capsulorhexis, and you see the wobbly lens, you see the entire lens move with traction on the capsule, and you know you're dealing with very loose zonules, as we would expect in this very elderly patient with exfoliation, and again, a 4+ brunescent lens. Now here, because of the laxity of the zonules, our normal steps do not cause a good rotation. In fact, we see displacement laterally of the nucleus. So if this occurs, it's because we don't have enough circumferential zonular tension to anchor the capsular bag, which wants to turn along with the nucleus. So here it's best not to persist and be overly aggressive, and instead we're going to use a Lester hook and our capsulotomy needle to create a 2-point fixation to revolve the lens, thereby loosening it in the bag under viscoelastic before starting the case. Another time we may have trouble rotating the lens is if it's very soft, because like a pillow, it wants to absorb the forces rather than to spin as a unit. And so here you see that we have difficulty after making our first chop in rotating the nucleus. So at this point, it is possible to go back in with the right-angled hydrodissection cannula and to re-hydrodissect, attempting to loosen both epinucleus and the nucleus. And in this way, we can see we can complete this case after that initial chop had been made. So the goal of hydrodissection is first to be able to rotate the endonucleus. Secondly, it's to be able to rotate and spin and have a loose epinucleus. And then the third goal is to loosen the cortical attachments to the capsule. So here again in this same case where we've had difficulty rotating the lens, it indicates we did not have a good hydrodissection wave. And so here you can see that the epinucleus peels apart, but doesn't actually rotate away. So we go back in with the cannula to loosen this last adherent quadrant of epinucleus before we can actually remove it. And this allows the safe aspirational portion of epinucleus. So if your epinucleus is firmly adherent to the hydrodissection itself, was not sufficient. The question of whether delineation is important depends on the technique, but for phaco chop, it is very useful. So after the first, we'll then tip the cannula a little posteriorly, right there, and that's going to create the second wave of hydrodelineation. Basically, this cleaves the epinucleus apart from the softer internal endonucleus, And when we proceed now to do phaco chop, we will chop the nucleus and dissect it in half without any sculpting. We'll rotate the nucleus and the epinucleus together. That's the hydrodissection wave was effective. And then you'll see how the endonuclear first fragment separates from the surrounding cup of epinucleus. Here's the next chop, and you again see how the endonuclear fragment is separating from the epinucleus, which remains as one large piece, serving as a soft cushion and buffer between the endonucleus and the posterior capsule. This also reduces the size of the endonucleus effectively by decreasing the diameter. So for this type of phaco chop technique, creating an epinuclear shell such as this with the hydrodissection is advantageous. And here again, showing that our hydrodissection wave was in fact very effective, we can see that this epinuclear shell is loose and can be aspirated without much difficulty. It's again the fluid wave that sheared the adhesions between the epinucleus and the capsular bag.
I highly recommend Dr. David Chang's book, Phaco Chop, while you are learning to do cataract surgery. It is filled with excellent tips, and the DVD explains each section and under different types of cataract. Now, there's sometimes you don't want to hydrodissect. First is a posterior polar cataract, where there's a plaque on the posterior capsule, and it often already has a defect in it. And if you hydrodissect, you can blow that out. So with posterior polar cataracts, you start centrally hydrodelineate rather than hydrodissect, and you actually core the cataract from the inside out. Use lots of viscoelastic under the capsule to help keep that separated, and so you don't get close to that plaque until you're near the very end. Hypermature cataracts often have liquid cortex in them under pressure. You want to make a very small capsulorhexis, or it probably is a little better to just make a small X in the center to help relieve the pressure and aspirate it out. If you try to make a standard capsulorhexis, it will almost always run out to each equator, and it's difficult then to recover from that. If you have very weak or missing zonules, you may want to not rotate the lens, because rotation is stressful to the zonules, particularly if they are very soft, like in pseudoexfoliation. And there are some techniques to remove the cataract without having to rotate it. Viscodissection is useful, and hydrodissection is useful in these. But then I'll show you one technique that you can remove the cataract without having to rotate it. This is by Dr. John Bullock and Ronald Warwarm.
A vertical groove is created slightly to the right of the center of the nucleus. Grooving is performed at zero vacuum to a depth of approximately 80 to 90% of the nucleus thickness.
So you make a
Note that we are making a
cut.
vertical groove in the nucleus, but that is not in the center of the nucleus. It's offset to the right approximately 30% of the radius of the nucleus. What we want to do is we want to divide the nucleus into 3 roughly equal pieces by volume.
Additional viscoelastic is inserted, and the groove is split with a nuclear cracker.
Now we have roughly 1/3 to the right and 2/3 to the left. We then make a second groove at approximately a 30-degree angle first groove. Again, down roughly 80 to 90%.
You want to go down until you get a good red reflex all across.
After additional viscoelastic is distilled, resulting in 3 approximately equal pieces.
The one to the left is roughly shaped like a half moon. The one to the right is shaped like a half moon. The one in the center is shaped like a piece of pie.
A Sinskey hook is used to manipulate and position the nuclear fragments for removal. The central fragment is displaced and engaged under high vacuum and aspiration. A pulse mode can be useful to keep the fragment in contact with the tip. High vacuum and minimal phaco power are used for removal.
And then once that fragment is taken in, you can often turn down the vacuum and or aspiration and take in the second 2 fragments, which usually come easier.
Note the fragment to the right is now spontaneously dislodged by the movement of fluid, and we did not do any manipulation to free that fragment. Approximately 30% of the radius from the center of the nucleus to the right, you go 30% of the way and make the first groove. You then swing over at a 30-degree angle and make the second groove, and that gives you then 3 equal pieces.
But it's a useful technique in cases where your zonules are very weak. And it's a good idea to have a number of techniques in your back pocket for problem cases like that. Now, what if you're going along fine, the lens is freed up, it's been rotating very well, and then all of a sudden it doesn't want to rotate? That often means you have a capsular tear. If that happens, leave the phaco tip in the eye, fill the anterior chamber with viscoelastic from the sideboard incision. Then you can remove the phaco tip, look and see if you do have a tear in the capsule, and use a technique to try to remove the rest of the lens without managing to push the rest of the cataract back through the capsular tear. Now, we'll repeat the questions from the pretest. Please mark your answers, and then we'll go over the correct answers. Okay, Lawrence, let's go back to question 1. Show us the choices and see which is right. Okay. Why do we need to do hydrodissection with phaco cataract surgery? You want to free up the lens to rotate it from the peripheral adhesions between the cortex and the capsule. And practically everybody got that. Good deal. Very nice. Question 2. Where is the cortex typically adherent to the capsule? Near the equator? Yes, that's the right answer. It is usually pretty well not attached other places, but it does vary. With very soft lenses, you tend to have wider adherence and more difficulty with rotation. Okay, question 3. Why do you need to decompress after each injection of fluid? Prevent capsular block. Actually, that is part of the reason that you do it. Push the lens back into the bag. If it comes forward, lower the intraocular pressure. To lower the pressure, you need to burp out some viscoelastic. And you want to prevent capsule blowout. That's the biggest reason. If you keep injecting without bringing the fluid back anteriorly, you run a significant risk of blowing out the posterior capsule and losing the nucleus into the vitreous. And it's not a good thing. Number 4. When would you not want to do hydrodissection? If they're loose zonules, not really. If there's a posterior polar cataract, there it's very important not to do hydrodissection. You want to do just hydrodelineation, work from the center out. Very soft cataracts, it's important to do hydrodissection. Those are the ones that are often hardest to get good hydrodissection on, and it's important. And you did very well on that. Okay, well, we have some questions now. Okay, in case of persistent capsular cortical adhesions, how do you make a safe hydrodissection? I think the very most useful technique I have found in those is to do the tangential hydrodissection, where you go around under the capsule, sweep around on one side as you're injecting, and do the same thing on the other side. Then again, decompress, pushing back, and if you do that 2 or 3 times, almost always you will free up the lens. Any other questions? Oh, type the answer. I'm sorry.
That's all right. You can answer live.
Okay. Okay, any other questions?
Looks like we have a couple more. Do you see those?
Oh, yes, okay. What's the best gauge of cannula for hydrodissection? I generally prefer about a 27 gauge. You can use 26 or so. If you use smaller than 27, it's often hard to inject quite enough to free it up. Okay. Is a J-shaped cannula superior to a straight cannula? Both of them can be used and work well. I like the J-shape that you bend, or the CHANG cannula. And either one of those works well. Just the standard J-shaped cannula, it's a little bit difficult to make sure that you have it freed up other than just sub-incisively where it's pointing. So if you use a J-shaped cannula, I would bend it about 45 degrees like Dr. Hart did for his tangential hydrodissection. Opinion on using a 10 cc syringe instead of a 3. I don't think you can control the injection nearly as well with a larger syringe. The 3, I think 2 or 3 is pretty much ideal. You can control your pressure much easier, and that smaller one is much easier to manipulate in the eye than with a larger syringe. Yes. Third is a 26 okay? Yes. Most are either 26 or 27. Okay. Why do sometimes hyphema occur after hydrodissection? I'm not sure. I have never had that happen. It could be from being a little bit too rough, or I'm not sure other than that. But that is not a good sign. If that happens, you need to inject viscoelastic, see if you can figure out where the bleeding is coming from, and then stop and figure out what you're going to do from that point. Okay. Do you want a sudden bolus or a slow one? In between. Inject a little bit. If you're not getting a fluid wave behind, inject a little bit more, and watch the fluid wave go across. Try to pretty much match the fluid wave going across speed to what you saw in the videos. Okay. Yeah, air works well if you have a small hyphema. Yes, absolutely. Actually, you may be able to see better and do better with air to try to stop a bleed rather than viscoelastic. Good suggestion. Viscodissection, if you're having a problem, often it works well. You can inject a little bit under the capsule around, and it particularly is useful toward the end with the posterior polar cataract to viscodissect the cortex away from the capsular bag. Okay. The fluid wave generally will go radial to the capsule as it's going across from the point of where you're injecting. Okay, how many quadrants to hydrodissect? That depends on the particular cataract. a good number, you only need to do one to free it up and rotate it freely. But if that doesn't work, I'll go across, inject again, and go through the same procedure of bringing the fluid around. You can do as many as you need to. If I don't get good rotation after 2 standard injections, then I will switch and do the tangential and sweep around as I inject until you can free up the capsule. Okay, if the fluid wave is not seen, that's where you generally want to burp out a little bit of viscoelastic and try again. If it's not still getting a wave, I would do the tangential hydrodissection and sweep around on both sides. Okay. If you have lens touch before surgery, how do you plan? Okay. You're talking about a very anteriorly prolapsed cataract. Essentially, you can have a flat chamber occasionally. I have seen that in patients who have glaucoma with a filter procedure occasionally. If you cannot deepen the chamber some with viscoelastic, you may have to remove just a little bit of vitreous through the pars plana. You get an instant deepening chamber if you do that. It's very rare to have to, but it's nice to know that you can do that. Okay. In case of persistent capsular cortical adhesions, how do you make a safe hydrodissection? I would try the tangential sweep, where you sweep around under the capsular rhexis. Or if that isn't working, I would probably go to that V-shaped procedure that I showed you at the end. Okay, what precaution advocate in case of lens touch? Oh, I'm sorry, post-vitreal retinal surgery during hydrodissection. If you're post-visco, actually, whether even at any time, if you had a normal depth of chamber, which I think is probably what you're talking about, but you go in and it immediately flattens, that means almost certainly means you have a posterior capsule tear. And you need to be very careful to release pressure. You may need to remove a little bit of fluid from the pars plana there to deepen it. But that's a very tricky problem because you probably already have a capsule defect. Okay, man, I'm sorry. I can't quite see the top of the first question up there. In case of preoperative rise of intraocular pressure, I would be very cautious to do anything if you're getting a very hard eye. That may mean that you have a choroidal hemorrhage or choroidal dissection. Often at that point, it's best to stop, make sure you're closed, postoperatively soften the eye, and come back in a few days. Can rotation, in case of a hard nucleus, where you can't see do the hydrodissection with a very hard cataract where you cannot see posteriorly. Gently hydrodissect, watch for the capsular rhexis to enlarge slightly, about 1 millimeter, and then you can tilt it to bring fluid back around. Okay. Can rotation be done without being sure of efficient hydrodissection? Yes. Yeah, if the lens will rotate freely, then you have adequate hydrodissection. So you want to make sure the lens will rotate. And you know, you may not have seen a fluid wave, but if the lens is freed up to rotate, that's the point of hydrodissection. Okay. Thank you for the comment, Dr. Raj. As I say, I've been working with residents for many years now, and it looks simple, but sometimes it isn't, and you need to have some different techniques to be able to. Okay, during a case of anterior capsule tear, during capsulotomy, should you do hydrodissection? That depends on how large the tear is. You would want to be very gentle and see if you can get the lens to rotate at that point. You can sometimes tell by the way the flaps on the tear go whether or not it's going back further. If it doesn't, if it stays pretty, if the capsule around it at the tear stays pretty flat, usually you're okay, but you want to be very gentle and try to stay away from the area of the tear as much as possible so you don't push it, or so you don't tear on around posteriorly. Okay. In case the rexus runs out, do you still do hydrodissection? You need to be very gentle. If the capsular flaps are rising up and flapping around a little bit, that probably means that you do have a tear on posteriorly. I would consider strongly switching to an extracapsular procedure at that point, because there's definite risk of pushing the nucleus back through a capsule tear into the vitreous. In case of traumatic cataract, advice: usually have zonular defects, and each one is going to be individual. Try to figure out how much zonular support you still have, and you want to do everything very slowly and gently. Anytime you have a problem, usually the first thing you want to do is fill the anterior chamber with viscoelastic, assess your options and the problem, and then try to proceed in the least traumatic way possible. Okay, hydroprolapse of soft cataracts with hydrodissection, and some of the lens in the anterior chamber. With very soft lenses, I'll usually just go ahead and phaco it there and try to use as much aspiration as possible and as little phaco power. And those are often hard to rotate. You can sort of viscodissect those out of the fornix. Okay, hard cataracts have very little space for the fluid wave, exactly. And looking for the expansion is easy with stained with trypan blue. Yes, I do the same thing. Any cataract that I cannot get a red reflex so I can see what I'm doing with the capsular rexus, I will use trypan blue. It's a wonderful help with safety. Okay, any others? Okay, case of persistent hydrocortical adhesions, that I usually will do the tangential, to where you inject all around under the edge of the capsular rexus. And that almost always will free even very soft cataracts up to be able to rotate it. Okay. In case of posterior polar cataract, avoid hydrodissection. Do not hydrodissect. You want to hydrodelineate and remove those from the inside out and viscodissect the epinucleus and cortex free. Trying to stay away from that capsular plaque as long as possible.
All right. Thank you, Dr. Downing. That looks like all the questions.
Okay.
All right. Looks actually we have one more if you want to
Okay.
just answer that one, last one.
Using the 26 gauge needle that you've used for the Rexus, I have not done that. I think you're much better using a blunt cannula. I think it's probably safer and probably more effective. So I use either a straight or an angled blunt cannula. I think it's more useful. If it works well for you, do it.